Welcome to the Oncology Data Advisor podcast, where we explore the latest advances in medical research and treatment. This episode is provided by i3 Health. I am Katie Cook. The results of recent trials, including the MATTERHORN trial for resectable gastric and gastroesophageal junction adenocarcinoma, are rapidly improving outcomes in esophagogastric cancers, making it critical for the interdisciplinary care team to stay up to date on biomarkers and tailored treatment strategies. In Module 2 of this podcast series, Dr. Yelena Janjigian, Chief of the Gastrointestinal Oncology Service at Memorial Sloan Kettering Cancer Center, will explore strategies for optimizing treatment of esophagogastric cancer, including approved and investigational treatments. This activity is supported by an independent educational grant from Merck Sharp & Dome, LLC. Free CME, NCPD, and AAPA credit are available for this podcast. To claim credit and obtain further information, including faculty disclosures, visit i3health.com/podcasts.
Hello, my name is Dr. Yelena Janjigian. I'm the Chief of GI Oncology Service at Memorial Sloan Kettering Cancer Center in New York City. And welcome to Module 2, Optimizing Treatment Strategies for Gastroesophageal Cancer. These are my disclosures, and the learning objectives for this module is to demonstrate competence in optimizing treatment strategies by implementing evidence-based sequencing techniques and considering the efficacy and safety profiles of available therapy. And we will incorporate complementary interventions and interprofessional collaboration into a comprehensive care plan to enhance patient outcomes. So we'll start by talking about targeting perioperative approaches in gastroesophageal cancer. First and foremost, Checkmate 577 demonstrated that adjuvant nivolumab improves outcome in resectable, high-risk gastric and esophageal squamous and adenocarcinoma. So what we look at is patients with esophageal NG junction adeno or esophageal squamous cell cancer after completion of chemoradiation and with persistent either node-positive or T-positive disease, so YPT1 or greater or YPN1 or greater. And these were both squamous and adenohistologies. Patients were randomized in 2-to-1 fashion to receive adjuvant nivolumab versus placebo for total treatment duration of up to a year, with primary endpoint of disease-free survival, secondary endpoint of overall survival. The initial New England Journal of Medicine paper demonstrated median disease-free survival improvement over placebo in this high-risk population after chemoradiation with adjuvant nivolumab of 22.4 months, median DFS, hazard ratio of 0.69, with a placebo of 11 months. Nivolumab improved DFS with 31% reduction in risk of recurrence or death and doubling of median PFS. What's interesting also, it appears that on treatment after chemoradiation, there was an increase of PD-L1 overexpression, so it made sense biologically why to target these tumors, and the benefit appears to be in PD-L1 higher population, but the approval was irrespective of PD-L1. However, in the recent years, ESOPEC trial and other trials, ESOPEC but also Top Gear, demonstrated that radiation has increasingly really not led to improvement in survival. So on the left, you have the randomized ESOPEC study looking at FLOT versus CROSS, and the overall survival with the CROSS is clearly inferior. 3-year overall survival of 57% versus 50%, 5-year overall survival of 50% versus 38%, so a real drop off. Why is that? Well, systemic chemotherapy is important. Most of our patients, when they fail, if they fail, they don't fail in the surgical bed, they fail distally, so liver metastasis, lung metastasis, and so forth. And the cross regimen of carbapenem and paclitaxel is just inefficient, insufficient to control the systemic disease. Looking at Top Gear, so the Top Gear took it a step further. This was a gastric study that looked like would we combine chemo and chemoradiation, so do ECX at the time and then do chemo radiation versus chemotherapy alone, and perioperative escalation of chemoradiation did not improve outcomes. The median OS of 49 months versus chemo plus chemo-RT of 46 months, 3-year overall survival of 58% versus 55%, and a 5-year overall survival of 46% versus 44%. So if radiation doesn't add much, what is the next step? With pembrolizumab plus chemotherapy, will addition of chemotherapy and immunotherapy be sufficient? So Keynote 585 was the first study to look at the outcomes with the doublet chemotherapy, cisplatin, fluoropyrimidine, compared to pembrolizumab versus placebo, surgery, followed by pembrolizumab chemotherapy. And so looking at the doublet regimen, looking at PathCR as the key interim analysis, and then also looked at a composite primary endpoint of PathCR, event-free survival, and OS in the main cohort, and then the safety in the flat cohort. So you could see here there's 1, 2, 3, 4, 5 primary endpoints, and you can imagine with the sample size, it may be quite complicated, although it's a large study, 804 patients. The alpha is split in such way that it became high risk. And though primary endpoint was met, the PathCR of 12.9 months, 12.9% versus 2%, the likelihood of translating this into survival was not yet known. And although event-free survival was improved, numerically, this difference was not statistically significant. The alpha was split too many ways, and the study was ultimately negative. 36 months OS rate of event-free survival rate of 54% versus 44%, with hazard ratio of 0.81. It does not cross 1, but again, the p-value of 0.0198 in this setting was not statistically significant. So where do we go from there? Well, you could select by biomarker selected patients. We learned about biomarkers in our previous module, and microsatellite instability is one of the most important biomarkers. And in this study, looking at biomarker selected population only using Nipiga regimen, which is the Nivo-Ipi regimen, clearly the impact on these patients is quite dramatic. 100% of the patients had complete resection, R0 resection, with 58% of patients had a complete response, compared to 12% in the other cohort. So in this population of patients with chemoimmunotherapy, has a high likelihood of complete response. It's not 100%, not as high as in rectal cancer, but certainly dual immune checkpoint blockade can be considered. Let's come back to all-comer, the MSS patients. What do we do in those patients? Will chemoimmunotherapy have a foothold? Well, the MATTERHORN study is a larger study, more definitive, simpler cohort, 948 patients, looking only at gastric and gastroesophageal adenocarcinoma, high-risk population, but first, untreated population, no evidence of metastatic disease, enrolling patients irrespective of PD-L1 status to receive durvalumab with FLOT versus placebo with FLOT. And once again, it's 4 cycles of FLOT perioperatively with durvalumab or placebo, followed by 4 cycles of FLOT postoperatively. By cycle, I mean doses. In this case, cycle was defined based on durvalumab, so it's 2 cycles here means 4 doses of FLOT. And then patients received durvalumab for up to 10 doses post-operatively, so for up to a whole year of adjuvant therapy, with primary endpoint of event-free survival, secondary endpoint of OS, and pathologic complete response rate. So the key takeaway from MATTERHORN is that the addition of durvalumab to FLOT improved event-free survival in resectable gastric and gastroesophageal adenocarcinoma. And this is the event-free survival we presented at ASCO in the plenary session and published in the New England Journal of Medicine. The primary endpoint was statistically and clinically meaningful difference in improvement. In fact, the hazard ratio is 0.71. 2-year event-free survival in the landmark analysis was 67% versus 59% with durvalumab or placebo. And the event-free survival median was not reached in durvalumab plus FLOT versus 32.8 months in the placebo plus FLOT, stratified long or rank p-value of less than 0.001. The MATTERHORN in the subgroup analysis, durvalumab and FLOT led to a clinically improved and meaningful treatment effect in all pre-specified subgroups based on the biomarkers that we selected and clinical biomarkers. So we saw improvement in event-free survival in patients greater than age 65, in Asia versus non-Asia cohorts, even in PD-L1 low or negative population, TAP less than 1 patient, the hazard ratio point estimates all favored in favor of durvalumab, including G-junction tumors and so on. So really practice-changing study for our patients in perioperative setting. The median overall survival is still maturing, and the data continues to follow. This was a interim analysis for OS that was presented, but the curves are already separating separating with a sustained separation. We're continuing to follow this, but the hazard ratio is 0.78, and the significance threshold was not yet reached for the p-value. The path CR rate is improved. Durvalumab plus FLOT 19% versus 7%, with a difference of 12%. Statistically significant improvement with the addition of durva to FLOT. Secondary endpoint of disease-free survival, looking at patients who had complete R0 resection, disease-free survival was improved with durvalumab with FLOT versus placebo with FLOT in those with R0 resection. Hazard ratio is 0.70. And what is often asked, are perioperative regimens with FLOT feasible? And what we did was showed that in a global setting, it is feasible to administer. And importantly, it does not compromise the likelihood of complete surgery and delivery. So 100% of patients nearly had all perioperative cycles. R0 resection rate was identical in both cohorts, 91% in both groups. And the number of adjuvant cycle completed was actually quite good, with more than half of the patients completing all year of adjuvant therapy. Safety and adverse events, there were no new signals that was demonstrated. Any grade adverse events and grade 3, 4 adverse events were very similar, again showing that most of the side effects come from the chemotherapy. So addition of durvalumab to FLOT did not significantly alter the toxicity profile of this regimen compared to placebo, and most of the side effects come with chemotherapy. Grade 3, 4 adverse events, possibly related to any study treatment, 60% with durva with FLOT versus 59% with placebo with FLOT. And grade 3, 4 immune-related adverse events were slightly increased, 7% versus 4%. But again, although the low-grade immune-related adverse events were slightly increased, 23% versus 7%, grade 3 or 4 immune-related adverse events are relatively rare. And here's a depiction. What do we see with this regimen? Most of the time we see nausea, vomiting, neutropenia. Other immune-related side effects are rare, but most of common side effects are chemotherapy, because remember, FLOT regimen is 5-FU, oxaliplatin, and docetaxel. The FLOT regimen, it's given every 2 weeks. On the study, we did not really mandate use of growth factors, so it was left up to the discretion of the investigators and the local guidelines. Practically, I think it's important to consider using this regimen with combination of chemo and immunotherapy using growth factor support. So we usually give prophylactic growth factor support with first cycle, and then with subsequent cycles we consider omitting it. Okay, so shifting gears now to talk about immunotherapy in first-line setting. Of course, Checkmate 649 is what demonstrated benefit of immunotherapy in first-line setting with chemoimmunotherapy. And the third arm of Checkmate 649 included chemotherapy-free arm with doublet anti-PD-1 plus CTLA-4. So we saw Nivo plus FOLFOX, FOLFOX alone versus Nivo-Ipi with dual primary endpoints of OS and PFS in all-comer population with gastric and gastroesophageal cancer, but the primary endpoint was enriched by PD-L1 CPS. And we demonstrated survival benefit for this combination with PD-L1 positive tumors, CPS 5 or greater. You see median OS of 14.4 months compared to 11.1 months. And in all randomized patients, hazard ratios also improved, hazard ratio of 0.79. There's an early and sustained separation in the survival curves, again, because there are a high percentage of PD-L1 positive patients. Most patients have some level of CPS overexpression, with median OS in all comers of 13.7 months versus 11.6 months. And when we published this data originally, this was a big difference, because prior to this point, the median OS for this patient population was, in prior studies, was well under 1 year. So this is the new standard that will be compared to in all clinical trials. The efficacy subgroup analysis by PD-L1 overexpression does suggest there's a dose-response relationship, and really for truly PD-L1 negative patients, tumors that are CPS less than 1, there does not appear to be a benefit. And that's what we struggle with in the clinic. How do we make sure the cancer is PD-L1 negative before we close the door on targeted therapies for the patients? And with that, we would need to really make sure that the quality of the sample is sufficient as we're moving forward, because in second or third line setting, immunotherapy is no longer available for our patients in the United States. What we are reassured by, though, in first line setting, there are still targeted options, even for PD-L1 negative patients if the tumor is claudin overexpressing. Luckily, there's claudin inhibitors now as well with the zolbetuximab, and certainly new generation inhibitors developed by many companies, including antibody drug conjugates. So how do we prioritize inhibitors in first-line setting? Do we use immunotherapy? Do we use claudin inhibitors? We use bemarituzumab or FGFR2b inhibitors once they become available? Well, I think the way that we demonstrate benefit is it's a risk-benefit ratio with the clinical response and also the duration of survival. What we know is that with immunotherapy, the patients who develop a nice response early on are the ones that are on the plateau of the survival curve. And the response duration is seen in all randomized patients, irrespective of PD-L1 status, but certainly in PD-L1 high population, the benefit is more robust. The complete response rate is 13% in PD-L1 CPS 5 or greater versus 11% in all randomized patients, and overall response rate of 60% in CPS 5 or greater versus 58% in all randomized patients. You could see here the benchmark survival and the duration of response is improved in this population. What we also know is that in first-line setting, microsatellite and unstable tumors really are important population of patients to target. We know these patients can be immune chemotherapy resistant. Can we use dual immune checkpoint blockade in those patients? The data is not quite there in metastatic settings, certainly in early stage tumors, potentially. And what we know is that a nivo chemo in immunotherapy in MSI high population in particular may have an important role. Median OS 38.7 months, hazard ratio 0.34. Again, early and sustained separation of the curves. Hazard ratio 0.34 is really why it's so important to make sure to test everyone for MSI status, particularly if you're restricting patients by PD-L1 status, because we do see sometimes PD-L1 low or intermediate cases that are MSI high, again, because of the difficulty with PD-L1 testing, sometimes with using certain antibodies. And often we get a question, well, what if you have a patient that has PD-L1 positive and Claudin positive? How do you stratify? How do you prioritize those patients? What if the patient has HER2, Claudin, and PD-L1 all in the same biomarker? Well, the way that I think about it is a clinical risk-benefit ratio. Of course, if the patient has any major contraindications to immunotherapy, that's an easy answer. You would use other targeted therapies. But if the patient is fit for combination therapy, using these data and Kaplan-Meier curves from the zolbetuximab studies, both Spotlight and Glow, but then immunotherapy studies, both Checkmate 649 and Keynote 811, may give you a roadmap of how to think about it clinically. We look at early and sustained separation of the survival curves, and we also look at, does this regimen lead to overall response benefit? Well, the good news is that, of course, all of these agents, especially at HER2-directed therapies, result in early and sustained separation, right? The zolbetuximab data in some studies, the separation may be later on, and also it does not cause improvement in response rate, and that's why in my list, I always put zolbetuximab after PD-L1 and Claudin inhibitors after PD-L1 as a fourth option. But Checkmate 649, there's early sustained separation, and we know that especially in those patients who have a response, tumor reduction, partial response, they have a durable survival benefit. And of course, anti-HER2 therapy shown here, that's the gold standard, early sustained separation, and it's an important target. So looking at immune and other adverse events, that's always a trade-off. Of course, immune-related adverse events can be serious, but they're relatively asymptomatic, and many patients can lead to just abnormality in liver function tests or thyroid function tests and so forth, endocrinopathies. While the zolbetuximab-related adverse events is mostly related to the fact that it's a tight junction protein and can cause quite a bit of nausea. And so those are the side effects you need to weigh. Certainly immunotherapy is much easier to use in the clinic. Zolbetuximab, Claudin inhibitors in general, there's quite a bit of medications involved, but over time the patients do get used to these side effects and they become also managed. So those are the trade-offs. Looking at better overall response in immunotherapy first-line studies really makes us favor immunotherapy in Claudin intermediate or even Claudin positive patients. If they're PD-L1 positive, we prefer immunotherapy in those patients because typically both Spotlight and Glow did not show improvement in the response rate, but it did show improvement from the immunotherapy trials with delta of anywhere from 15 to 10%. So anti-PD-1 therapy may also be better for proximal tumors, as shown in Keynote 859, while Spotlight data shows that perhaps most Claudin, so gastroesophageal junction tumors, immunotherapy, may be the best option, while in Claudin, claudin inhibitors are really restricted to the stomach cancer. Again, it's subgroup analysis, but it also gives you a pause. Gastroesophageal junction tumors can present with quite a bit of symptoms. So if they're PD-L1 positive and you really need a response rate, that would be a better option for the patient. So the key takeaway from the data we showed is that, again, there's a lot of these inhibitors on the market, and the greater magnitude of benefit in a biomarker-enriched population as you're considering and weighing these options between HER2, PD-L1 overexpressing tumors, claudin overexpressing tumors. These patient clinical factors we'll cover in the next module will become important. Plan ahead for combination strategies. Many of these targeted therapies, including claudin inhibitors and FGFR2b inhibitors, are now being studied in combination with immune checkpoint blockade and chemotherapy in first-line setting. We know that in first line, while the patient is still symptomatic, inducing the response is so important. And the future is bright for gastroesophageal and gastric cancer, especially in the biomarker-selected population with targeted therapies. These patients have a lot of hope and options. Thank you for your attention.
Thank you for listening to Module 2 of this podcast series. To hear more about biomarker-guided approaches in esophagogastric cancer management, check out Module 1. Be sure to subscribe so you'll never miss an episode. To claim CME, NCPD, or AAPA credit for this activity, visit i3health.com/podcasts. While you're there, you can check out our other free educational offerings at i3health.com. And don't forget to follow us on social media for free CME, NCPD, and CPE, as well as news, exclusive interviews, and more.